you don't miss it. And so now audio is on and working, and the presentation will get started.
Three.
Inslee?
So which one is it?
Awesome. Let me know if there's anything else you need from me. Sorry. Oh,
Well, I don't want to sit on this for quite some time. I don't know the history and impact page. I should have I mean, because if you take it outside,
it's just.
or I want to put it on. You know, I want to put it.
Justin, are you logistics for the last session too? Yeah, I'm pretty sure Justin is.
So he's covering the two.
Justin, you're in here for the next 2 sessions? Okay. Oh, are you moderating? Yeah. You're not members. Still here. You have the slide answer, right? Do you have the slide answer? Yeah. Sorry, no. The PowerPoint stuff, I want to get your. But I can like pretty like certain so. Already. So. Not the first time this happens. So. Here. I'm sure of this. Yeah. Yeah, so well, I have to sit here out and because of course audio should be up and running. Check once. This does not. Please say me. I think it's something towards Friday. Thanks. Yeah, you're right. The thoughts were like signs. And that is more fun. Are you thinking you say it here? Yeah, I was going to do. I started there's an issue. So I was right. So this. And you guys are going to be to that. And that's that's how. Yeah, it goes handling to stairs. Let me go ahead and just see what I'm so she had another yeah. I guess that's fine. Yeah, I'm just saying this. So right. We're gonna play exactly 30 minutes. Yeah, you want just find the whole. I mean, I just I work all here. It's true. I just don't see how things are. I just want to resist show hands that it's I guess that's great. Yeah. So let's yeah, right. Just up from the idea. She's secure. Okay. That's a big. I thought you said 30 minutes. Okay, all right. I checked the Zoom is recording and screen sharing the audio turned off. Okay. And you guys are gonna click. You guys are gonna click through this your presentation, right? You guys know that you're gonna click through it. Yeah. All right. Welcome, everyone. Hello. Please take your seats. My name is Justin Graham. I work in the Office of Community Health Improvement for the UVM Health Network. Super excited to be here with you all today at the Health Equity Conference 2024. I'm going to pass it right over to our first group of presenters and have them come up to the mic over here and introduce themselves and their project. And so, yeah, take it away.
Hello, everyone, and welcome to our workshop session rooted in hair care at the University of Vermont Medical Center. My name is Alicia. This is Pascal, Vanessa, there's Laura. So Vanessa, Laura, and I work at the medical center in various roles, from executive assistant, co-leading a racial equity employee resource group, nurse management, and medical laboratory science. We also have a few other members here. We have Holly, we have Allie, and Justin. We have been a part of this project centered in hair equity from its inception. From the beginning of just having ideas of hair equity brought to a BIPOC affinity space to where we are now, which is a practice that nursing staff can now offer as a part of a routine procedure for caring for patients when it comes to cleansing and getting patients back to their optimal health picture. Next slide. So the more we connect and interact with things, the more their significance increases in our lives. Whether you're spending 5 to 10 minutes a day or 5 to 6 hours once a month, it holds a lot of sway in our lives. With a show of hands, how many people feel like they spend a substantial amount of time thinking about their hair? Okay. At the start of this project, I remember just trying to connect with people and getting a sense of how people feel in Vermont about hair care, and a lot of different responses. Some responses were not so much, some responses were, of course, and of the responses that were not so much, I kind of delved a little deeper. If you were to wake up with green hair, would you just look in the mirror and say, you know what, looks good, I'm going to head out? Probably not. If someone came to you and maybe just decided, I'm going to shave half of your head, is that something that you think you'd just be okay with? Probably not. Hair plays a significant role in all of our lives. And this project helped highlight that it stems across all cultures. For the next few minutes, I'd like to talk about the cultural significance of curly and coily hair. A culture that has experienced a lot of grief and negative perceptions when it comes to hair care is the African culture, past and present. In ancient Africa, so we're talking early as 15th century, hair care was a way to bond with family and to connect with friends. Hairstyles would often indicate aspects of a person's identity, such as marital status, fertility, tribe affiliation, social rank, age, and wealth. Other intricate styles also reflected spiritual connections and divine communication, as the head being the highest part of the person's body and closer to the divine. During the period of slavery, enslaved Africans had their heads forcibly shaved. From hearing about how significant hair was within that culture, we realized that was a dehumanizing act and one of the earlier forms of cultural eradication. Hair takes time and conditional love, effort, and a specific knowledge base in order for it to reach its full potential. As enslaved Africans, as their hair grew back without the correct tools and oils that they used in Africa, they relied on things like cooking grease, sheep combing tools for their own hair, without having the time to connect with their culture and regain a sense of belonging while in a foreign land. Now, fast forward to the 1960s with the Civil Rights Movement. Curly and coily hair in its natural state was worn specifically as afros instead of being chemically straightened, and this became a symbol of Black liberation and power. Afros were popular with Black activists, artists, and academics. Movements such as Black is Beautiful aided in the attempt to redefine Eurocentric beauty standards that embraced all of the unique features of Black hair, bodies, and skin tone. Despite the work that has been happening, Black hair still experiences discrimination today in employment, schools, Hollywood, and even the White House, due to the associated stigmas that were used to stereotype. some examples that I'll highlight is Michelle Obama, former First Lady. She came out and stated that while in the White House, she was apprehensive of wearing her hair natural or even wearing braids because she didn't want there to be any scrutiny or for the focus to be on her hair versus it being on her husband's work in the White House. Zendaya, a biracial actress, wore faux locks to the 2015 Oscars, and a news anchor said she smelled of weed. She's a vegetarian, doesn't smoke, doesn't drink. Where did this assumption come from? Another example is Andrew Johnson, who was a high school wrestler and in 2018 was forced to cut off his locks in the middle of a game because the referee said that he would have to cut it off or forfeit the game. These examples brought us to the Crown Act. The Crown Act, which stands for Create a Respectful and Open World for Natural Hair, was born in 2019 to protect those who experience discrimination tied to race-based hairstyles. It protects hair texture and protective styles in the workplace and public schools. This law is currently recognized in 25 states, with Vermont joining that in 2024. Now, the picture on the screen depicts, but isn't limited to, what comes with maneuvering life in a culture that prioritizes the go, go, go. The quickest way is the way. And that low hiss of, if this doesn't affect my personal life, do I really need to be engaging with it? We are the business of healthcare, a business that's founded on helping those in need get well again. As we continue to recognize how our mental health impacts every aspect of our lives, let's think about what it means when fear, emotional distress, loneliness enter our lives at a time when we're most vulnerable. Now, what comes to mind when you see a slick back bun, an afro, a completely shaven head, or a mohawk? Whatever comes to mind, we observe it from a lens of our conditioning, unconscious or conscious. And that comes from our upbringing and the social media that we ingest. The chart on the right shows what hairstyles people choose to wear based on their hair type. The chart on the left shows the different hair types. On our scalp, we have different hair types spanning from very curly or coily to straight strands. Some individuals have a mixture of all of these. One thing that connects all hair types is sebum. Sebum is the body naturally secretes this oil, and it helps with keeping the hair and scalp moisturized as you go through your day. The body produces this throughout its lifetime, though the amount that it produces varies depending on age and what you do with your hair on the regular basis. The curlier the hair, so when you see type 1A or type 1B hair, the sebum can just glide directly down the hair shaft. So this makes the hair look shiny, wet, greasy. That's sebum. Now with the curlier hair types, you have some twists and turns before you can get to the most vulnerable part of the hair, which is the tip. So with curlier hair, the sebum doesn't always get to the end of the hair, which is the oldest part. So when you have hair that's dry, when you have scalp that's dry, what happens? It breaks. You're more prone to infection with broken skin, whether it's on your scalp or the skin on your body. In knowing this, when it comes to maintaining curlier hair types. When you're washing your hair, you need a little bit more than something that's going to strip oils and dirt. You need something that's going to help you retain the moisture that you might not be getting from sebum because it hasn't been able to get to the entire hair shaft. You need something that's going to help you get moisture into your hair shaft. So that's a little bit of what sebum does for the hair and why there's the difference of straighter hair kind of having that look versus curlier hair. So I guess that's all I have to say about that. Does anyone have any questions? Does that make sense? Okay, well, now I'll turn it over to Vanessa, and she will be conducting the second half of our workshop and talking about some of the products that we brought on board, as well as some other gems as we get to the more interactive portion of the session. Thank you.
Okay, can you all hear me pretty well? Okay, great. I wasn't sure if this is on. So everything that Alicia just spelled out for the importance of moisturizing your hair and scalp as well shows that we really had to do extensive research on the companies that we were going to get these products from that we would bring into the hospital. And so we focused on products that were designed for hair patterns from the wavy to the tightly coiled. And we had 15 product testers within the community. Some were employees, and they all were compensated through a grant that we were able to do that. And they evaluated 33 different products from these different companies, and we collected feedback over 137 surveys from each product that was tested from each person. And so from those surveys, we were able to take the information and the data, and we realized, or we came back with Mixed Chicks being the best product that we can bring into the hospital for curly and coily haired patients. Coily haired patients. The shampoo that you see on the left-hand side, and all these products are out on the tables too. It's really designed to moisturize the hair. The current shampoo that we have in the hospital is not focused so much on moisturizing, so it didn't address any of the needs for coily and curly haired folks. And the conditioner is fragrance free, so it also conditions and moisturizes, but it also is great for people who have sensitivities to fragrance. And then we also have a leave-in conditioner, and that is to just lock in all the moisture after we clean the hair and add moisture to it. We also want to lock that moisture in that we're doing, all that we're doing for the hair. And then the styling cream at the very end, not just for looks, it also does all the important steps that you did 1 through 3. It's going to be that final step to lock in the moisture, all the things that you did for the first few steps. And so in addition to these products, we also have the accessories on the bottom row here. So we have a wide tooth comb, we have a flexi brush, and then we also have the bonnets. And the bonnet, all of these are great tools, but we like to stress that the bonnet is the one that you should offer to patients with coily or curly hair, to every patient that has that kind of hair, because even if they're not going to wash their hair while they're in the hospital, the bonnet adds protection. So if a patient is laying on their pillow, it will help reduce frizz and friction on the back, so it will help prevent snarls. And also it just is another way to retain the moisture as well. And so we'll go into a little bit of the process next. But I will go through it quickly because I want all of us to be able to have time with the mannequins. So all the tables have a mannequin with different hair types on it. And so I'm just going to go through the process for a patient who has limited mobility. If you have a patient with limited mobility that you're washing their hair in bed, you'll have a wash basin like this. And the patient, she's okay. So you'll have the patient have their neck right on the dip in the basin here. And you will have a towel and maybe a chuck underneath to protect both the patient's body from getting wet as well as the linens on the bed. You'll have a wastebasket with a spout here because when you're washing the hair, all the water will go down into that. And some of the other tools besides all the combs, shampoo and such, you'll have a little pitcher for the water to wet hair, a little spray bottle as well, and more towels as well. So the first step, before you even get to this point, the first step is to ask the patient, how would you like care for your hair? Most patients will say, they'll want to do their own hair. And some patients won't need anything because you don't wash hair, don't wash curly hair every single day. So if they're just in the hospital for a couple of days, it might not be on their wash routine that they're in the hospital. So they might not need anything except for that bonnet we showed earlier. But you first ask them what they need. And so if they do want the full wash experience, then you'll get all these tools out and you will position yourself at the head of the bed and you'll remove the headboard so that you can be behind. And then you want to make sure that you get their hair adequately wet before you start sectioning the hair off into parts and detangling it. So you'll spray the hair liberally with a spray bottle. And once we get our hands on it, might be hard for everyone to see what I'm doing, but once we all get our hands on that, be able to do it yourself. And so once you get the hair pretty wet, you would part the hair into different sections, and then you would take a comb and comb through at the ends. You want to hold the hair firmly and just work through the ends and go up to the top that way. And if you get any resistance, you want to bring the spray bottle back out and wet, because if there is any kind of resistance, we're going to hurt the patient, cause them discomfort, and you're also going to cause breakage and damage to their hair. So you want to make sure everything is very wet and able to brush through. And then after you do that, you would use the shampoo and shampoo the hair pretty well, massage it through the scalp all the way to the ends. And then you would take your water basin, water pitcher, and wash the hair out very well. And you would dip on this to let the water run into the wastebasket. You're going to repeat that step with the conditioner as well. Get it into the scalp, massage out. And when you have the product in, also I skipped over the step, but you will use the brush at this point. Once you have the product in, you can brush through for the conditioner. And then after that, you will wash the product out again, making sure that the water is running clear so that you're not leaving any of that product in their hair. And so once all the product is out, you'll press the hair dry or a little dry. It won't dry completely, but you'll put a towel around their head, move the basin, put a pillow and a towel underneath them. And that's when you would put the leave-in conditioner and make ssure that it's all hair. You'll use the brush to brush it through on the ends, going all the way up to the scalp. And then you would finish with the styling cream. And with wet curly hair, you want to make sure that you don't just put it in a bun or stack it up, because it does take a while to dry. So you'll want to lay it out over the pillow, or you can also separate into 2 ponytails, anything to make sure that the hair adequately dries. And then once the hair is dry, you'll be able to offer them a bonnet to put over. You don't want to put a bonnet into wet hair, because then that will prevent it from drying completely, and it also can create snarls and knots in the hair as well. And so you always want to check in with the patient after you do this process to make sure that everything works well and that they were happy, and to also receive feedback to see if there are any improvements that we can do in the future. And I think that is pretty much it. There is a video through Cornerstone that describes this process a little longer and more detailed, and you also have a hair model and hair expert doing it. So Pascal is doing my hair. So in Cornerstone, with the education there, you can see the whole process there. But I think we have some time to get to our mannequins, and we have all the tools there. So feel free to touch all the products, get your hands on the hair. Okay. Sorry, I forgot. This is Pascal, who's our hairdresser, so she's keeping me honest. I missed something, so please.
I think something that she can't just skip because the time is so short. It's very important when you finish washing, while the patient have the towel and even conditioner in the hair, to rotate them every 2 hours. Because if you keep them in one position, the only one side of the hair is going to be dry and the other side will eventually knot itself up. So it's very often for the patient that are not movable to actually move them. Those who are movable, they know exactly what to do, but those that cannot are not mobile. So you kind of just want to rotate them from one side into the next side. And when you do that, you want to take the brush. So if, for example, if they were on the left side and you're moving them into the right side, you just take the brush and brush out the side that was laying down. And you want to hold from the bottom and brush it from the top and work your way down. And second thing was right at the beginning, after you spray the water, you want to section the hair into 4 parts to make it easier for you to comb and less stressful for the patient neck. And because remember, some patient you will find out that their hair was really knotted. Like if somebody been in the hospital for 2-3 weeks, their hair will be knotted at the roots. So if you're trying to just brush it from every angle, it's pull the neck and it would be very discomfort. So you kind of want to just part it with the telecom. You part it into 4 sections and you work each section at a time.
Thank you for asking. You didn't, we missed it. And so we have the napkins at the end of the table, and feel free to, we're going to be walking around and answering any questions that you have. So how about 7? We have about 5 minutes to do that, so feel free to get close to them. Generally. What's your readings?
AMC, I gotta find that.
Okay.
We have 7 more minutes. So yeah, we don't have the whole session, so we're it's like
Yeah, I'll do that.
We'll just head back to your seats, so we can start the second half of the workshop sessions. Is this you guys? Yeah. Okay. And this is the first slide. Okay. To share first. I don't want to by trying to yeah. All right. I'm just gonna go check to make sure this is it. It's very cool.
Can I change? Do I need the clicker to change slides or?
No, you can change them right here. Just so you guys know that the so let me just ask you. Check, check. Start. Thank you so much to Vanessa, Alicia, and Pascal for their presentation. I'm going to hand it over to Jill Reinhardt and her team. So, Jill, you want to go ahead?
Hi, everyone. We're going to shift gears here, and thank you all for joining us today. I'm here today with sort of the end of a journey and the beginning of a journey. I'm a primary care pediatrician, have been for many years, and I work at the Children's Hospital in primary care pediatrics. Also direct the pediatric residency program. I'm here today with two parents, and Sandy Julius will tell a little bit about her story, our story of her daughter Kate, and Kelly Griffin is with us from our Patient and Family Advisory Program today, and we'll each take a little time to talk about it. But so we're going to talk about a gap that's real and palpable in care for our young adults with intellectual disability. And as was quoted to us this morning during the plenary, of all forms of discrimination and inequalities, injustice in health is the most shocking and inhumane. So I'd like to start us off by thinking of people in your own life who have an intellectual disability, and what has their experience been in healthcare? First off, does everybody want to raise your hand? Do you know someone in your world who has an intellectual disability? Thank you. That's great. And think to yourselves about what that healthcare experience has been. And then as healthcare professionals, what training did you receive in caring for these people? Either officially and part of residency as part of your professional development school, or through life, extracurriculars, camp counselors, teaching, or lived experience. And this is myself with Kate, Sandy's daughter.
I do want to talk about sweatshirt.
Yes. So now I'm going to hand it to you. There's a microphone. You can share how
you guys hear
your
me?
story is.
So Kate is a medical unicorn, right? She's had cerebral palsy, she had epilepsy, she has had multiple shunt revisions and surgeries. But she was also way too verbal for her own good and her mother's sanity. She sang nonstop, and she believed with all of her heart that she went to Yale and that she had been asked to coach the pickleball team there, and that she was very exhausted by her classes in biology and French. So she would ask me all the time, can you help me have an exam tomorrow? So I love that picture because Kate knew Jill from the day she was born. And we all just said, yeah, you're going to Yale. It's exhausting. Oh, girl.
Oh, so as you can tell, we both have family connections to this topic, and this is where we see where our families are, right? Usually outside in the hospital. I grew up with a brother and a sister who, unbeknownst to us, had what's now known as a mitochondrial disorder, neuroprogressive. My younger brother Ross was born when I was a senior in high school. My sister was born when I was 7, and they both, through different trajectories, lived to the age of 36. That was the extent of their life course. And throughout my brother's journey, especially, I take on more of a care provider role for him as we went through the medical system together. He touched pretty much every disability there is. He we learned when he was about 9 months old that he was profoundly deaf, so our family spoke sign language. My sister was hard of hearing and had voice, so that was a little easier for her to communicate. And then, my mom was a pioneer, as mothers of children with disabilities are. And started a school for the deaf, which my brother then proceeded to get kicked out of because of his behaviors. So he was, I guess, labeled as ODD. I think it was just narcissistic talk, but anyway. But and he then developed a lot of behavioral concerns. Both of these young people, it was a value in our family from my mom and my dad that we become as independent as possible. So both of them in their young adulthood were able to live in a safe setting as adults with other care providers providing services for them. We were very lucky. Do you want to share more story before I go into data?
Well, we don't have that kind of system in Vermont. So our young adults stay with us. And, there are a lot of people working on this. And Jill's not giving enough credit to her mother because her mother created a system of housing and across several states. So, when Jill and I became really good friends, it was always like, well, what would Peggy do? That was the question I would ask myself when I was at the end of my rope. What would Peggy do? What would Jill's mom do? Because Peggy was a super badass and just created things out of thin air. So yeah.
Out of necessity. Yeah. So, and what our journeys independently brought us together. Kate was doing mighty fine. She had her challenges. She lived with CP and an amazing MRI of it wasn't congruent with who she presented. And then she developed a disease that took us a long time to diagnose, and that was Crohn's disease. And we're still recovering from her diagnosis of Crohn's disease. But what it led us to was the convergence of who's making medical decisions for a 20-something who has guardianship by her mom when a nurse comes into the room and says, I need to take your blood pressure, and Kate says, no, you effing aren't going to do that. And that's a kind way of saying it. So we had a lot of roadblocks that I just never anticipated having through this journey. So I'm going to but talk a little bit about some of the disparities of this population in general, and then really hope to bring it back and think about concrete things that we can do to improve the experience that we've had with Kate and Ross and others. Just so you know, it's an estimated 16 million Americans live with intellectual disability, about 3 to 5% of the total population. I love this. This is from Matthew Holder, who has an amazing model of care for individuals with developmental disability and autism. But if the square is sort of everybody, The smaller square is that square of those with intellectual disabilities. And there's a lot of overlap in the different types of diagnoses. So we have, within the intellectual disability community, there is Down syndrome. There's a little bit of crossover with those with Down syndrome into the autism spectrum. There's fetal alcohol spectrum disorder, which is probably a lot bigger than that little purple square, and we just don't diagnose it enough. Fragile X system and CP, as you can see, also kind of so we're talking about a lot of different types of brains and a lot of different types of needs that fit in this one category, and different bodies that feel things differently. And we're going to taught this in medical school. So some more statistics. This comes from the Special Olympics in our own state of Vermont, that those with intellectual disabilities are 3 times more likely to have arthritis, 5 times more likely to have diabetes, twice as more likely to die before the age of 50, 3 times more likely to be admitted to a hospital by ER docs, twice as likely to be obese, and twice as likely to have cardiovascular disease and asthma. And the health inequities for those with intellectual disabilities come from all different for all different reasons. There are higher rates of pregnancy complications for this population, more than 6 times likely to die from COVID. They're less likely to be screened for cervical, breast, and prostate cancer. They are at risk for social isolation, which leaves them with less emotional supports, and experience a suicide risk that is 3 times higher than the general population and 6 times higher for those who are autistic. And this is the one that I keep coming back to. They're twice as likely to die before the age of 50 than adults without intellectual disabilities. Also, people with intellectual disabilities die on average of 20 years earlier than the general population in the United States. And generally, these diseases are not, or deaths are not because of conditions that are associated with their intellectual disability, but because of other inadequate access to things like good health care, underprepared health workers, and lack of policies or systems in place that can support them. And then we add the not uncomplicated source of racial disparities onto this. Just even looking just at the autistic diagnosis, children who are Black, our average age of diagnosis for autism is 7.5, where for a white child is 5.5. We want to get it down to like 2 for everybody, but it's amazing the discrepancy there. And the likelihood of getting a child diagnosed at that first visit to the specialist is much longer, 75% for Black children and 58% for white. Finally, last year, the NIH designated that people with disabilities is actually a population with health disparities. So they've caught up. Oh, this was supposed to be a picture of Kate. It didn't get in there. Oh, maybe not. This is the right one. Other contributing factors, we all have unconscious biases. There are physical access barriers, unmet social drivers of health, lack of education for us as healthcare professionals to meet the needs of people with intellectual and developmental disabilities. The law has slowly caught up to provide some equal access and equal rights for those with intellectual disabilities. Starting in the 70s, Section 504 of the Rehabilitation Act prohibited discrimination in the school setting for those with disabilities. The IDEA was 1975, which protects those kids and children with disabilities to have access to education and that access in the home. So we have that Birth to 3 program. In 1990, with the ADA, that we were prohibited to discriminate against Americans with disabilities, including in healthcare. As part of the Affordable Care Act, you cannot discriminate against health based on sex, race, color, national origin, age, or disability. So clinicians, we don't often know a lot about caring for people with intellectual disabilities. Maybe we don't have very many as our patients. We might feel uncomfortable or even fearful. They may believe that having an intellectual disability makes life worse for people no matter what. And they just don't know how to communicate well with people. There's a Council on Disabilities Health Equity Framework that came out a couple years ago, and really stating that we need comprehensive disability clinical care curricula that should be required in all U.S. med schools, nursing schools, and healthcare professionals to teach. So physical access to care, surprisingly, is actually one of the things that we do better than others. So in a survey of over 2,000 sites in California, most health settings had handicap parking spaces, exterior access like ramps, enlarged bathrooms with grab bars, but only 8.5% had things like height adjustable exam tables. And only 3.5% had things like a scale. So the weight for children, especially, but as they grow, is really an important statistic in health, and we don't have ways to access that. So exactly. So offices, clinics, and hospitals where clinicians work are often missing really important things. Larger spaces, especially, and ways to correctly change insurance companies so that people and resources to help with that, and also things like durable medical equipment and access. Very challenging. One thing that's unique in this population is that when young people with intellectual disabilities turn 18, they need to have an adult guardian. And in our state, the young adult and families need to go to the court to determine what type of guardianship suits their child best, voluntary or involuntary, total or limited.
And this judge said that in all of his years, presiding over these cases, no one had ever asked him for a selfie. Okay.
And then this is for you, Sandy. You wanted this slide, but no, this was about parents of young adults with intellectual disabilities are battle weary, right? We know them. And Kelly is. Oh, okay, all right.
Rage, and Kelly's gonna give me excuses.
Ah, okay. I'm gonna leave it to you then. Go for it.
Physically and emotionally difficult to care for somebody with special needs. And I have probably spent 400 nights in the hospital over Kate's 22 years. Kate did pass away, by the way, a year and a half ago. And so we do know more if we are well educated and in touch and paying attention.
Privileged.
And privileged. And I spend a lot of my time battling, or I spent a lot of my time battling on behalf of parents who don't have privilege or don't have access to the resources that they need to navigate these incredibly difficult systems. So, it was really part of my identity to go above and beyond for my community. And we do know our children best, and we're tired. So sometimes when we're tired and pissed off, we act out, right? And sometimes Logan would come into the hospital to visit Kate, and I'd just be like, I'm going to kill someone. And he'd be like, take a break, go, sit down. Christy did the same. Emily's done the same. Jill's done the same for me. Just rage a little bit. And I feel, because I'm so crazy, that the rage does make change, right? Because I've seen change come from that rage. But Kelly is a softer, kinder human.
So what in my role in patient advocacy, I deal with a lot of parents like Sandy who have just been fighting a lot of battles along the way and trying to impact the healthcare system and make improvements for their kids. And we were talking a lot about how it's not just in healthcare that these parents are fighting. They're fighting at school, they're fighting in their communities and trying to do the best for their kids. And they just get to a point where they can't really articulate other than being angry or focusing on something that may seem so insignificant, but it's where they feel like they can impact the most change.
Yeah, that's a thing that Kelly and I talked about a lot. You get in a tunnel where you're just so mad that there's not an accessible bathroom on Baird that that is just nothing in our world, right? But you just get focused on the wrong stuff. So you need friends like I have here that are like, oh, dude, like, let's try to get Kate back in the comfort zone. You know, like, that's something change things for everybody, not just Kate.
Yeah. You know, currently our families are struggling with things like inaccessible playgrounds. There's a shortage of staff everywhere in the schools. So parents of kids with disabilities are being told that they don't have IEP services because they can't find people to implement the IEP. And some clinical teaching points that I think I wish I had learned in medical school, and I like to continue to teach this to others. Those with intellectual disabilities and autism have a different experience than what we were taught in medical school of things like pain. Missed pain, I would say, is every parent that I've worked with a young person with intellectual disabilities fear is that they're going to miss something painful. I had a patient with autism whose parents, literally watched them fall and land with their palms on the wood stove, and they whimpered once, and then until they actually saw the blebs on the hands of the blisters, didn't realize they were truly a significant burn or not.
No one knew. She didn't complain about it. She didn't have the same sensory experience that somebody with normal physiology would have. She had great medical care. She had doctors loved her, but it went undiagnosed for way too long until it was really too late.
Yeah, Kate had a cutaneous, a skin form of Crohn's that its first clinical presentation was probably when she had a appendicitis that fistulized to her bladder, which can happen. Yeah. And yeah. Well,
Feel the rupture, and I knew she was sick because she was, peeing blood. So it was like, oh, it's a UTI, it's UTI. We spent a whole week in the doctor's office, then 2 days in the ER.
We finally got admitted when we recognized with the abdominal CT that it was a walled off abscess with a fistula to the bladder, which is why she kept having her dirty urines. So what we're left without sort of this altered experience of pain is really looking at behavior and trying to understand what means what. That could be irritability, that could be temper tantrums, hitting on the head, and opposition. And then really important from the medical side too, to have documentation of things like vital signs, like kids in their teens shouldn't have a resting heart rate of 135, that something's going on there, either dehydration or pain or something. And that can be really helpful to put in our notes as we're sending these people into different parts of our healthcare system. Smiling, enjoyment, understanding what that looks like at baseline, understanding what sleep patterns are at baseline, and then things like appetite are really important. Behavioral changes can happen there too. As adults with intellectual disabilities age, we talk about the fatal 5. These are conditions that happen not incidentally, but as part of neurodevelopmental illness that can cause death. So that's choking and aspiration, constipation and all of its lovely side effects, infection and sepsis, dehydration, and seizures. So why do we need a change? You've heard a little bit about our lived experience. What do we do when a patient like Kate or my brother Ross refuses care or is told that, that they're too combative? That's their safety concerns. And when Kate was 22, I made a valiant effort to have her admitted to Baird 5 to our inpatient peds unit. That wasn't a thing there. But now we're moving on to recognizing that kids, young adults like Kate, really do need that expertise of a pediatric nurse that understands the Sandys of the world, but also understands how you negotiate with a person with intellectual disabilities. It's a have to, do you want to take your doll or your blanket to the doctor's office, but you're going, much more complicated when someone's 22. and have had these behaviors ingrained. So atypical presentations of common diseases, challenges to providing routine preventive health care. So, things like cervical cancer screening for a 29-year-old with an intellectual disability who doesn't use tampons, let alone be examined that way. That difference of experience of pain, age-related access issues. There's a wonderful program called the Comfort Zone that helps support children through painful procedures who have been traditionally up until age 18. And again, we've had rules about where adults can be treated based on their age, just not necessarily based on their developmental stage. Over the 28 years that I've been a pediatrician, I've had multiple attempts at creating teams with adult clinicians to have warm handoffs for these adults who will need twice-a-year visits, and that the pediatrician, maybe we can hang on to them to 24, 25, 26, but we have no place to transition to. That's a problem. And some practical things like not being able to find the guardianship papers in EPIC. And we talked a little bit about that adult model of care and change. So, yeah, go ahead.
The adult specialists not having the time down in their schedules for these patients who will need longer visits as opposed to the short visits where they can typically get them with the pediatric specialists.
Yeah.
And not allowing the pediatric side of the hospital to talk to the new adult caregivers. So Jill was basically breaking into our floor in our room, checking in on everything, because she knew that, they were all fine doctors, but they didn't know Kate, and she did. So.
And who Kate or any of our patients are in the hospital is not who they are 99% of the time, right?
Right. So, Kate looked really sick, but Jill knew, that's not Kate. We need to do this, 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 and this. So, yeah.
So working with our adult side for them to recognize and see the importance of the medical home, of the people who've known her for years, and that picture of them in the hospital is not who they are in the community, who we want to get to. So some things, what can we do? I'd love to hear from all of you. But ensuring that our programs and spaces have physical access, incorporate disability etiquette in the staff training, which is really just about looking people in the eye and talking directly to you. It's not that hard, but it does need some training.
Kate, why are you walking like Frankenstein? Just they think they're funny. And they're so not like Ella. Does Ella do anything other than arch? A kid with serious CP. And
words matter.
Bad.
Absolutely. So moving ahead, things that we can do. We are working on expanding the comfort zone up to age 26. We've got some first ones going through this November. Love to work with people who are interested in training their staff on working with people with intellectual disabilities. Thinking about if there's a place within your practice for improving care. What about transition to adult care? Successes and barriers. Any of you feel adequately prepared to care for individuals? If so, why? I think I'll close with if you have any doubt about it, speak directly to the young adult with a disability and offer them your direct attention. Would love to hear any questions, comments. Thank you. Both these probably our resources.
So let's give one more round of applause for both presentations. Thank you so much, everybody. We have about 10-15 minutes for some Q&A. I'm going to invite the first group of speakers up here as well for that Q&A session. So if you'd like to come back up, Alicia, yep, there you go. There. Pascal, if you want to come up. And all I'll do is say is if you can use either this mic for the Q&A or the mic that you guys have over there and speak into it for our people who are online. And if you can also do me one favor is maybe rephrase the question or re-say the question so that people online can hear what the question was too. So folks in the audience, any questions for our two groups of presenters? Or even just reflections, maybe? Maybe a reflection or two? Don't be shy.
There's some hands up.
Chris.
That's quiet.
Okay, so yeah, I think.
Have you guys discussed like appropriate documentation within Epic of specific places where a patient with an intellectual disability, like there can be notes for providers? Because I feel like I've opened up charts with patients who've had autism and the parents have called who have guardianship, and the only note is patient has a guardian. Like there's no other additional information, and you can see like, oh, they're on their problem list, they have autism, but there's nothing else of like how we can support them.
Yeah, so the question is there anything in the EPIC in the chart that can help plan care for kids with or adults with intellectual disabilities? And yes, so we have, so Kate had a complex care plan and it's a flag. There's a complex care flag that's right under the name in Epic. You can click on and see our care managers have a snapshot, and that could be as detailed as a metabolic emergency plan for our kids with pan-hypopit who need steroids whenever they're stressed, to I need the Purell removed from the room because I will like spray it all over the counters. Like those kinds of things that are really important to care. There's also now POKE plans and plans for painful procedures that can go also in there, and we're working on developing those for this age population, but really important. And part of the backstory here with Kate is we never did pain right with Kate. And so by the time she was 20, if she wasn't knocked out and really supported in the comfort zone, it wasn't going to happen. So those early experiences are so key and important to prevent medical trauma, essentially.
So admissions, like we are talking about, doing more flagging so that when you're going to the hospital, Kate was a frequent flyer, man. We knew what we needed. We knew where we wanted to be admitted to. We knew what kind of room we needed. So just, I know that we're working on that too, getting some admissions stuff written down. Like this kid, she needs a single room. Her mom's going to be there. You're stuck with Sandy. So, so we're working.
Oh, Logan.
Thank you both very much for helping us think about not just the concerns of intellectual disability and hair equity, but also the systems issues. And I think building off the last question, I have a question for the folks who provided the hair equity information. So much of the healthcare system is based in Epic and what you can click and what has a billing code. Have you found ways to take your advocacy work and this important aspect of people's lives when they're under our care and find ways to get it into Epic so that people have some continuity across their 2 weeks in the hospital or their repeated admissions, so they don't have to be asked every time they come in, do you like the leave-in conditioner or not? Do you need the sort of support around washing your hair that you accepted on the first admission? Or has that been a roadblock because it's not considered a traditional driver of health status or something?
If Allie feels comfortable, or Laura, I'm going to invite one of you two up here since you are the ones who practically work in Epic, and what type of note maybe you would put down for something like this. As long as you speak into the microphone.
I think that's a really great point that we have not tackled or addressed at this point. And I think it does speak to, I think it overlaps a lot to think about where we do things really well and we do them in pockets. And when we have small units, we're in small populations and how we can do a great job at that. But then when you spread out beyond that. So I love this point. I would say no good answer, but a good challenge to work on that for this, because absolutely having to relive and re-ask and traumatize our patients going through the same stuff is an unmet need. So I love that. Thank you. And while I have the mic, I just want to thank you for all the ways that you're honoring Kate's life. And I think that's beautiful. And, speaking from inpatient pediatrics, I think her legacy and your message is absolutely continue on. And I think that's really beautiful. So thank you.
Much.
Yeah.
Something that I do want to add is that a part of this hair equity experience is connecting with the patients. And the patient's needs are not always going to be the same, right? So even though right now we don't have systems in place that are like you can look in the patient's chart and see, okay, like this patient actually will probably only want a bonnet. They probably won't want their hair washed or connected with. But with a lot of different ethnic hairstyles, sometimes I might come in with braids, sometimes I might have natural hair. So that prescription isn't going to work every single time. So connecting with the patient, asking the patient what's going on with them, building that trust, because it's not always going to be the same person that's taking care of them, especially in a hospital system. So I think we can use this point and this process to rebuild that trust within the medical system of saying, hey, what do you need in this moment? Is it would you like your hair cleansed? Would you like just the leave-in? Would you like us to detangle? I just do think that at this point, working towards that is really important. Instead of just saying, okay, I saw in your chart that you may just need a bonnet, so here you go. I feel like having that conversation with the patient is really helpful, and I think it will help that patient feel better and safer, and maybe even calmer in having a conversation with that healthcare provider. Thanks.
All great points. Question in the back. Yes. Maybe wait for the microphone if you don't mind. Go ahead, Marcella. Marcella.
So recognizing that there can be a lot of trauma associated with hair care in the BIPOC community, and also with the appreciation that perhaps a large portion of our staff are not part of that community that would be administering this care to the hair. Is that training in Cornerstone a requirement or suggestion? I'm just thinking from my own lived experiences as someone with mixed race curly hair, and if someone that perhaps looks different than I do is then administering that care to my hair, is there a level of confidence instilled that there is a training associated with this, or what does that look like, that conversation prior to just saying, oh, we have these products and going forward?
Yes, and I think this is it is required. Laura, if you'd like to speak more since education, but definitely it is required. And there are also skill sessions, but Laura can probably speak.
Yeah, I mean, we're excited. We just got the report that we're at 83% completion in the training so far, and it is a requirement for all new employees. And we're working through kind of filling in the gaps and making sure that that's really enculturated completely and wholly into our practice. So we're really excited. I think we rolled this out in actually February. I was saying October, but February. So we're kind of, I think, ironing out those final certainties that we feel when you go onto all units. We now have stock across the board, all units inpatient, and that all staff have had access and have at the elbow updated information. I think the enculturation piece will take continued time, right, in terms of people's comfort. I think, Pascal had to run out, but she, has been a great, actually, live subject in the hospital and helped us sort of at the elbow in real time, which has been really helpful because we don't have a super high patient population in pediatrics, at least. And when we do, often our average length of stay is a day and a half. So kids are in and out and not necessarily always we're doing enough things that drive them crazy. Resetting their hair is not the thing that their family chooses to do. So continued work, but we are excited. And it was one of the things that we were really intentional about, particularly as we're rolling it out to the network, which Justin and the gang are integral in rolling this out network wide, is that we live and breathe this in all ways.
Actually, do you know?
So one thing that I keep thinking about, and somebody had mentioned, is taking care of someone's hair. Often they're never offered the option, let alone the products, and the time commitment needed to give them the time and care that they need might also not be realistic for a lot of nurses. So in the future, is there going to be any hopes that there's more of a dedicated time allotted for that type of service? Or is it really just going to be, oh, we don't have time right now, or we do have time right now?
I think Ali, being an LNA, probably would have a great perspective on this. Yeah.
So I just want to make sure I understand the question correctly. You're asking if there are parameters that we can embrace moving forward to make sure that there is enough adequate time and just mainly compassion for people who have those needs that maybe in an acute care setting like where I work currently, where that's not always realistic or feasible. Something that, so I'm an LNA on North 3 at the hospital, and that's cardiovascular and neurology. It's an acute care unit. We see a lot of people post, pre, open heart surgeries. And when we run into, well, I can only speak to my experiences, but if the patient is oriented and very much more active in their care, usually what I try to do just for cultural humility piece, also just integrating the patient-centered care collaboration piece, is to ask them, hey, this is what I have for time right now. What can I help you with? And if you need more time, are you comfortable with someone else coming in if I'm going to a different shift or if I am leaving? A lot of the times, as Alicia stated earlier, there are people who will want the products but do not request our assistance. And for people who are nonverbal per se, I've had a couple of clients in community as well as in the hospital where it's really important to seek, if they have family present, seek out their thoughts about it. You know, what is the most respectful way to coordinate that care? Sometimes if family is there, it's very helpful because then the patient is already comfortable and with that assistance, and it also helps us out on our end when we have that limited time. So I would say, to be succinct, it's not really a succinct topic at all. It's very abstract. There are a lot of layers to it. To ensure, I would just say that it's really important to also have that care guide that we passed out to just accessible, so people understand that it's not just a one and done kind of deal. It's very much an ongoing collaboration with people to make sure that they're feeling respected, that the experience that you're perceiving is also the one that they are experiencing. And so I would say it's always a work in progress. That's a great question. But usually it very much requires the collaboration of the person that you're caring for.
Yeah, I think we can get one more question. I'm gonna actually move to this side of the room over here.
Thank you so much for your presentations, both presentations. I am curious about, particularly thinking in the realm of hair care, and the combination of the, traumatic experience around hair and the traumatic experience around hospital setting, for BIPOC individuals. I'm curious about, in addition to rolling out this program, I'm wondering what kind of system level interventions or changes can happen to help the conversations and help the hospital be an accessible place to have these conversations. Yeah.
I think that just to that point, and I think there's no perfect straight answer, but I think that one of the parts of the Cornerstone module that I think was really important is getting to how to have these conversations and how to make them natural and normal. And if we can talk about our hair, then what else can we talk about? Because so much of this translates, right? This is like basic hygiene, and yet it's all the things. And so that was a really important part of why this was such a thoughtful and comprehensive process, because it is so much more than hair. And so if we can get that artfully done, and I think that a little bit kind of makes me circle back to the question around how do we enculturate that further, is when we do have a patient and we are intentional about how we're assigning our LNAs that day, right? If I have someone with head lice, I'm going to make sure that I assign an LNA to spend an hour in that room. And so thus I'm going to do this for our patient who needs their hair care to take an hour, right? And so and that's just something that has to happen at all levels, right? That's our charge nurses, that's our bedside nurses saying, this is a thing, this is important, and we're placing that importance in the same way we would if they had a complex wound that needed a really long dressing change. And so it happens in all the ways and all the messaging, and I think that that's the piece that I think was really crucial. And if you haven't and you weren't assigned the Cornerstone module, you still can access all of it. It is electively opted in for all indirect care patient care providers, but it was assigned to all direct patient care providers. So I would encourage you to interact with that. It is really thoughtfully done and really comprehensive. So hope that helps.
I'll just add one more thing because I was part of the project team, is that there's another YouTube video that just talks about the project more overall and why this project's important. That's not necessarily training specific. It's more than just hair. You can find it on, if you Google it correctly on YouTube, you can find it. It's a great video. It's like 5 minutes. And many of these people star in it too, which is great. So they were heavily involved, start to finish, in every aspect of this project. So let's just give one big round of applause for both of our presenters today. This is the end of the session, and we have about 10 minutes to transition to your next rooms. If you're going to be either using the bathroom or staying in here, the next session starts at 3 o'clock. And Vanessa wants to make one more announcement.
Yes, and so if anyone is interested, we do have a few extra products up here, not the ones on the table, those are all our official testers, but if you would like, if you have curly hair, textured hair, come up and we have 3 samples for you. Yeah.
Okay. Yeah, it's okay. Everything else, right? Okay. Cool. It's